Hi, everyone. Thanks for joining us. We're going to give it maybe a minute or more or two for a few more people to join us, and then we'll get started.
There might be people coming in as I'm speaking, so will you be able to let them in as well?
Yeah, yes, definitely. Would you, would you like to get started, and then people can join us um, as they come in over the next few minutes?
Be great. Yeah.
Hi, everyone. I'm Ashley Shork. I'm the FCVC Innovation Program Manager. Thank you for joining. I would like to introduce Dr. Hamid Ghanbari, who will be speaking with us today. Dr. Ghanbari is a cardiovascular electrophysiologist at the University of Michigan Frankel Cardiovascular Center, where he treats patients with complex arrhythmias. Dr. Ghanbari was a fellow at Providence Hospital and Medical Centers and a student at Wayne State University, the University of Michigan School of Public Health, American University of the Caribbean, and McMaster University. He leverages mobile applications, wearable sensors, signal processing, and machine learning to explore the dynamic relationship between symptoms, effect, and functional status in patients with atrial fibrillation. He's also the co-chair of the Frankel Cardiovascular Center's Innovation Program. And he is going to speak to you today about a digital health program that he is leading at the University of Michigan Frankel Cardiovascular Center. So welcome. And I will turn it
Thanks.
over. Mhm.
Thanks so much, Ashley. It's wonderful to be invited to the webinar series that you've arranged for us. I'm following up on a fantastic webinar series that we did with Dr. McManus and Dr. Singh. And if you haven't heard that, please go to our website and listen to it today. And my goal today was talk a little bit about the opportunities in digital health and particularly with the focus in atrial fibrillation, and then kind of talk you through how we went ahead and implemented all the things that we've learned through research and clinical care into a program that now we call digital health program, which is really focused on cardiovascular disease, but the major focus for it right now is atrial fibrillation. These are my disclosures. So current AF management is definitely inadequate. We have lots of patients that come to see us with atrial fibrillation, and what we do typically is that we see them after they've had atrial fibrillation for a long time, and we prescribe medications, and often many procedures are performed in these patients to try to make them feel better. And unfortunately, despite the fact that we can reduce and eliminate atrial fibrillation, and many times, lots of patients continue to have symptoms, and many recommendations that we give them for lifestyle, sleep, and social connection improvement are not implemented because we're not really following up on them. It's not really just do these things and we'll see you in the next clinic. So oftentimes our treatment is too little, too late, and it's not comprehensive enough to address the whole patient. Now this is a circle that I like to think about whenever I'm thinking about treating any disease, particularly cardiovascular disease. We are focused on four major areas. The first area is that we don't want patients to come in to see us, and that's prevention. And the way we achieve that oftentimes is by giving patients lifestyle recommendations, such as eating healthy, quitting smoking, and improving their sleep habits. There are screening interventions that we could do for in cardiology, is typically diagnostic testing like ECGs, pulse checks. They're very sporadic and they're not typically continuous in the screening phase. Once we are suspecting someone of having a particular disease like atrial fibrillation, and there's tests that we have to perform in order to diagnose the disease, and those are typically clinical grade ECG and Holter monitors. And if we do confirmed diagnosis, we prescribe them medications or treat them with a variety of procedures like ablation procedures. Unfortunately, what I described to you doesn't really address all aspects of disease, particularly the social determinants of health. It doesn't really address different treatment options and patients' perception of those treatment options. It doesn't address health behaviors and the need for change in those health behaviors. And oftentimes, education and emotional states are a very big determinant of how people actually feel with the disease that they have. So our current strategies, the four that I described to you, really don't address all of these very well. Now, there's an opportunity with digital medicine to address many, many different aspects of disease in a way that we've never been able to do it. Now, particularly if we use wearable data, because wearable data enables us to see patients in a whole new way. Traditional healthcare is a result of episodic healthcare encounters that give a very incomplete picture of health for each patient. With digital wearable data, we were for the first time able to gain insights in patients' health and well-being by continuous and remote monitoring. As a result of that, you have a whole new form of data and biomarkers for healthcare that are really novel and are critical as we learn to incorporate them into clinical practice every day. This is an example, one early example. Actually, this was funded by, this research was funded by one of my patients, where they helped us develop a mobile application to collect information about heart rhythm and symptoms in patients with atrial fibrillation. And that mobile application is called My Atrial Fibrillation, created here at University of Michigan. And we looked at symptoms over a period of time, 30 days. And at the same time, we collected a lot of information like heart rhythm, activity. We found that a lot of patients that reported severe symptoms, their severity of symptom was highly associated with how badly they felt emotionally. So if they reported lots of negative emotions, they reported more severe symptom. And interestingly enough, this effect was independent of their heart rhythm, kind of highlighting the fact that if you don't address the whole patient, especially their emotional status, you really are not able to kind of get at the root cause of their symptoms. And digital data is a very interesting and novel way of kind of getting this additional information that you wouldn't otherwise be able to get. Another very interesting opportunity is development of digital biomarkers. Now, you basically, digital biomarker is defined as a digitally measurable human behavior or physiology that has clinical relevance. And for example, it could be something like heart rate that you're obtaining from a PPG from a wearable device. And it allows us to get a better signal for safety and efficacy of our treatments, even progression of disease, and also allows us to understand disease in a new way by creating a whole new set of phenotypes that we can design targeted and precise therapies for. Now, this is a framework that I like using as a way of understanding what a digital biomarker is and how we should think about it. Generally, you have an input, which is your concept of interest, and you have a way that you measure that, and then you have an outcome that you're interested in. So, for example, if you're interested in if someone has atrial fibrillation or not, you have a measurement process, and that measurement process has traditionally been a 12-lead ECG, and the outcome that you're looking on that 12-lead ECG is presence or absence of a P wave. So so that's the way. So presence or absence of a P wave is the biomarker that you're looking for on that way, and the way you're measuring that is a 12-lead ECG. Now, if you take that and think about it in a new framework, which is a digital biomarker framework, we can think of a whole new ways of measuring what we are really interested in using wearable data. So for example, if you're interested in presence or absence of atrial fibrillation, you can, instead of getting a 12-lead ECG, you can digitally collect ECGs using a handheld device, like in a live core or smartwatch. And on that single lead ECG that you're getting, absence of, presence of absence of P waves on a smartwatch ECG is what we call a digital biomarker that you're interested in for you to be able to detect atrial fibrillation. We've done lots of work in this area, and this is some of the work that we did early on with the wearable patch for diagnosis of atrial fibrillation, where I think a lot of you are very familiar with this. So what we did is that we took all the signals that was coming from that wearable patch and we push it into the cloud, and we run this very sophisticated deep learning algorithm on. And for every 60 seconds of the ECG, we decide whether the patient has atrial fibrillation or not atrial fibrillation using the deep learning neural network. And with that, we were able to really, with high degree of accuracy, determine whether the patient had atrial fibrillation and determine how long they had atrial fibrillation. Because you can imagine when you're getting loads and loads of data like we were getting, it's impossible for a clinician to really look through every single beat to determine if patient has atrial fibrillation or not. So having really robust networks that you could deploy is really important. Another way of thinking about this, instead of getting continuous ECGs from a wearable patch, you can get ECGs from a handheld device. This is something that we use very commonly, and it's one of the major devices that we use in our digital health program, and that's the cardiac mobile device that allows us to obtain a 3-lead but also a 6-lead ECG. And then we can determine whether the patient has atrial fibrillation or not using the same kind of networks that I described previously. Now, so now I showed you that we could really, with a high degree of reliability and specificity and sensitivity, determine whether the ECG that we are looking at has atrial fibrillation or not. Another area that's very important and interesting for us is screening for atrial fibrillation. Now, many patients have atrial fibrillation, but many of them don't have symptoms that triggers them to go see a physician or get an ECG like I described in my previous slides. And oftentimes, up to 10% of these patients present with their initial diagnosis being a cerebrovascular accident, a stroke. The good news is that if we catch them early enough, we can give them a blood thinner, which stops them from having a stroke. So you have the perfect combination where a screening program may be helpful, where you have a disease that's very common, you have terrible outcomes associated with it, like a stroke, and if you treat it in a timely fashion with the blood thinner, you can actually prevent those terrible outcomes from happening. Now, there's many different ways you could do this. This is some of the work that my colleagues have done at Mayo Clinic, and we are doing very similar work here at University of Michigan, where we could take normal sinus rhythm ECG in patients that have had no history of atrial fibrillation in the past. And we can take that ECG, compress it, and run it through one of our algorithms. And with a high degree of reliability and with a sensitivity of 79% and specificity of almost 80%, we can predict whether the patient will have atrial fibrillation 90 days from the onset of the initial index sinus rhythm ECG. So basically, you take a sinus rhythm ECG and you could tell or predict in the future whether they are, what are the chances of them having atrial fibrillation in the future. This has been taken one step further, where generally the screening programs that we had done had failed because we don't really pick the right population, the population that's at the highest risk. We kind of, in the past, we've been like, oh, let's take a bunch of patients who are older or have risk factors for atrial fibrillation and let's screen them. And I think that's one of the main reasons why screening programs for AFib have not been successful in the past. Now, taking a single 12-lead ECG as a way of determining whether this patient has high risk in the future is a very good way of determining a high-risk population. So you could take that 12-lead, determine who has high risk for having atrial fibrillation in the future, and then institute a screening program in that population. The screening program would be something as simple as on-demand ECGs, or continuous ECGs, or even a watch where you can extend the monitoring period up to 6 months to a year. They did this in this study, and they found that that they are able to, with a high degree of confidence, catch a lot of patients in the future with a more intensive screening period. So I think that's probably a really interesting area and probably a future of kind of how we're going to go about determining whether these patients should be screened or not. Now, screening doesn't have to be necessarily done using a PPG device, or sorry, ECG device. It can be done with a variety of other things. And one thing that's commonly used, almost 20 to 30 patients, my patients actually have a device like this, and that's a wrist-worn watch where it has the capability to measure your heart rate with what we call photoplethysmography, a PPG device, where the device emits a light, and that light goes through your skin and bounces off the capillaries, and then a photodetector receives that reflected light back and creates a particular waveform, what we call the PPG waveform. Now, the interesting thing about the PPG waveform that it has a very interesting and distinct AFib signature. So you can see on top the PPG waveform of a normal sinus rhythm, what it looks like. And in the middle, you can see what the AFib PPG waveform looks like. So visibly looking at it, it's much more irregular. The amplitude of the PPG signal is really changing. And that signal is very distinct from a noisy signal where the signals are missing, or there's definitely artifact present. So if we take you back to the framework that I introduced to you earlier, which is the diagnostic digital biomarker framework, just to kind of refresh everyone's memory, if our legacy measure was the concept of interest was whether the patient has atrial fibrillation or not. We had a legacy measurement process, which is a 12-lead ECG, and you look for absence of P wave in the 12-lead ECG. Now, extending that to the PPG signal, you're still looking for presence or absence of atrial fibrillation, but now the way you are measuring that is a digitally collected PPG signal from a smartwatch, for example, or it could be from a phone. And then you use algorithms to classify whether that PPG signal is atrial fibrillation or not. This was the kind of the earliest work, some of the earliest work that was done at Stanford looking at this particular problem. And they took lots and lots of PPG signals, and they ran it through a convolutional neural network, and then they determined whether those 30-second ECGs were atrial fibrillation or not. And you can see on the right that they were able to really, with high degree of confidence, determine whether those were atrial fibrillation or not for every 30-second interval. And it was, interestingly enough, it was very robust to noise. So this was some of the work that we have done here, where we use a clinical grade smartwatch that you could wear. And we did it a little bit differently in that we took PPG signals for every 15 minutes. And then at the same time, we had a gold standard, which was a continuous Zio monitor, a patch that the patients wore for 2 weeks. And for every 15 minutes from the gold standard, we determined whether the patient had atrial fibrillation or not. And we achieved, our algorithm achieved a sensitivity of 96 and specificity of 98.1%. So really wonderful and world like highest in class performance. What this allowed us to do was, because we're looking at every 15 minutes, unlike other smartwatches like Apple or Fitbit, where they require the patient to be stationary or they don't look at the intervals continuously. We're able to determine the burden of atrial fibrillation, how much atrial fibrillation the patient has over a monitoring period with a very high degree of confidence. We could tell you not only whether you've had atrial fibrillation over the monitoring period, but how much atrial fibrillation you've had over the monitoring period. This watch also has a capability to get a confirmatory ECG. So once you get a signal from your watch that patient has, you may have irregular rhythm, then you can get an ECG to confirm whether you have atrial fibrillation or not. So obfuscating the need eventually to order additional testing. Now there's lots and lots of issues that we still have that we have to work through, such as there's lots of false positives, watch quality, ECG needs to be improved, and identifying the at-risk population like we discussed. But I think those are all problems that over time we're going to be able to solve. So the question of false positives is something that from a clinical perspective, we're very interested in, because definitely the fear of all clinicians is that everyone's going to get a watch and they're going to call me 24 hours a day and all I'm going to be doing is answering these false positives. So we sympathize with that, and I think that that is an appropriate concern and something that definitely needs to be addressed. And the framework that we like to use and think about when we're dealing with this is the same framework when we originally brought in the continuous ECG monitors, where you have to have systems in place to process all this data and create reports at the end of the monitoring period where a clinician can look at quickly and determine whether the patient had atrial fibrillation or not. So this is our first attempt at creating that system where in our framework, a healthcare provider orders a smartwatch like I described to you. It's clinical grade FDA cleared watch. Patient wears the smartwatch. They either take ECGs voluntarily or as a result of irregular rhythm notifications. Then that PPG and the ECG data goes to a cloud where certified cardiac technicians read those. They sort through the false positives. They generate a report that is then overread by a healthcare professional and then transmitted to the healthcare professional so they can make the right therapeutic decisions on. And this is a much better way of going about it than a patient coming into you with oftentimes I see in my clinic with the Apple Watch with thousands of ECGs where, really as a busy practicing electrophysiologist, you really have no bandwidth for dealing with that in one clinical visit. Some of the other interesting things that we've been thinking about and tackling through the study was generally there's been a lot of concern about detection of atrial fibrillation during activity. So we looked at that specifically by looking at patients in low, moderate, and vigorous activity. And you can see that the performance for detection of atrial fibrillation was really great in low and moderate activity. And obviously, it's much lower when patients are in vigorous activity. But the interesting thing and important thing to remember is that vigorous activity oftentimes does not comprise a significant part of a patient's life. So in our study, it was only 1.7% of the time. And if you have clinically meaningful atrial fibrillation, definitely it's not something that's going to be just 5 minutes or so. You're going to have a lot more of it. And we're going to be eventually able to catch it. And we saw that in our study, that even though we missed some intervals because of vigorous activity, overall, we were able to detect atrial fibrillation, almost all of the patients, if they had clinically meaningful AFib. Another area that we're very interested in, we have a couple of large ongoing studies now, is the effect of skin tone and detection of atrial fibrillation. Like I told you before, PPG is a light-based technology where you have to shine light through the skin and then you look at that reflected light back. So if you have darker skin tone, there is some what we call loss of coverage, meaning that there's going to be intervals, when you're looking at 15-minute intervals where you're not going to be able to detect atrial fibrillation, or that there's not enough high quality signal where you may not be able to detect whether the patient has atrial fibrillation or not. So we looked at all the skin tones, and as I described earlier, there was loss of coverage. But the interesting thing was that although there was some reduced coverage on an interval level, so there were some intervals that we missed, on a patient level, we were able to detect all patients who had atrial fibrillation, even when they had skin tones that were the darker skin tones. And again, it goes back to the clinically meaningful atrial fibrillation episodes are long enough that although you miss some intervals, overall, you're able to detect AF in all of those patients. And another concern is that if you miss some of those intervals, does it take you longer to detect atrial fibrillation in patients with darker skin tone? And we showed that really that's not a concern. The time to detection of atrial fibrillation is the same regardless of the skin tone using our technology. So some of the other digital biomarkers that we're interested in is the LV systolic dysfunction. So going back to our original framework of legacy measure being ejection fraction measurement, the way you measure it is an echocardiogram, and on the echo you look at whether the patient has reduced ejection fraction or not. With the new technologies, you're still looking at the concept of interest is whether the patient has low ejection fraction. And the way you do that is by looking at a digitally collected ECG, and you decide based on algorithm whether that patient has low EF or not from the ECG. Now, this was the recent work done by my friend, Dr. Tia, who showed that you would take the watch from take an ECG from the watch and use that to predict whether the patient has low ejection fraction or not. So I think that's going to be another interesting thing to implement, where as we implement these into clinical practice, to kind of see which patients need an additional ultrasound to see whether they have low EF or not. Another one that we're very interested in is measurement of QT. Again, traditionally, we've measured QT using a 12-lead ECG, but you could do that using the handheld wearable ECGs. To do that, our concept of interest, again, remains to be duration of the QT interval. And the way we measure that is that using digitally collected ECGs as opposed to a traditional measurement techniques of using a 12-lead ECG. This is using the cardiac mobile device that I showed you, and this is recently got FDA clearance for measurement of QT. So you can see that instead of bringing many of these patients into the hospital for drug loads or other reasons that you may be worried about arrhythmias, you can simply use these devices at home and monitor their QT intervals, so they don't have to come in and cause so much discomfort for the patient and use so many of healthcare resources unnecessarily. Okay, so one of the important things that we've been thinking about and really working through is developing a platform so we could take all that information that I described previously, put them together. Now you have continuous data from different diagnoses over a period of time. You have lots of data from EHRs. You have lots and lots of radiology, pathology, wearable data, environmental data, genomics data. I'm kind of putting them together, integrating them, putting them together, and then identify new biomarkers that you are generally not able to do before. And we've kind of started to do a lot of that work in our digital biomarker development pipeline, where we take a lot of this data from sensors, wearables, implanted data, and mobile apps, combine them with clinical data. We do a lot of pre-processing, exploratory data analysis, and feature engineering work, and then using the really interesting and sophisticated analytical techniques to come up with new digital biomarkers that may be helpful for not only diagnosis, but treatment and prognosis of disease. This is some of the work that's kind of coming in. We're doing with combining some of the not only single set of information, but combining clinical information and then multi-sensors. So combining, for example, an ECG with an accelerometer data in this study, where we took patients that had atrial fibrillation. Sometimes when you have atrial fibrillation, your heart can go really, really fast, but it's maybe because of the fact that atrial fibrillation is the problem, or maybe it's because you've just been walking really fast. So we combined ECG data with accelerometer data, and we were able to, with a high degree of confidence, to predict whether this patient was in atrial fibrillation, because it was clinically significant atrial fibrillation with rapid ventricular rate without activity, or whether this patient had atrial fibrillation with rapid ventricular rate because of activity. So you can tell that that's going to be really important for a clinician, because they can decide whether this patient has a clinically meaningful atrial fibrillation with rapid ventricular rate. We took it a little bit step further, and we were able to predict whether this patient within 5 minutes would develop atrial fibrillation with rapid ventricular rate associated with low levels of activity. This is some of the phenotyping work that we've been doing, and like I said before, when you get lots and lots of information about emotional state, heart rhythm, symptoms, you can kind of start to see whether different phenotypes emerge. So when we looked at continuous emotional information, continuous symptom information, and continuous heart rhythm and sleep information, we start to see phenotypes emerge where majority of the symptoms are because of the emotional state. So you can imagine in a patient like that, a treatment that focuses on improving the emotional state is going to be much better than doing an ablation, for example. Now, this is our work with the work using the ECGs that I described in the digital biomarker pipeline, where we took over 2.5 million EKGs from our database, and we have developed algorithms for classifying many of these rhythms. And the first use of this technology is for quality control, where you can run these algorithms in the background to see where misclassifications are happening. Why are you getting so many noisy signals, for example? So it's like a really interesting use of this technology for improving the quality of obtaining ECG and classification of ECG. We have lots of other projects looking at using this technology for discovering new biomarkers for in coronary artery disease, in heart failure, and in atrial fibrillation. Another area that we're interested in, and we're kind of slowly starting to think about and implement, is implementation of digital therapeutics. And digital therapeutics are clinically validated software applications to treat and manage medical conditions. They have to be clinically validated, obviously. They, and you know, the interesting thing about these is that you can assess engagement, you can personalize, and kind of deliver it on time, on demand, when the patient really needs it. And this is important, as I will show you, because many of the sooner you can deliver therapies from the onset of symptoms, you're more likely to benefit patients. This is one of the digital therapeutics that's developed for atrial fibrillation, where patients with atrial fibrillation and risk factors were given um, uh, treatments to treat their risk factors digitally, and over a 6 months period of time, they were able to improve their health-related quality of life significantly. So very inexpensive, can be delivered virtually or remotely, and definitely can improve a lot of health outcomes in an inexpensive way. And it could supplement many other treatments like ablations that we're giving. That this is just highlighting that when the patient's severity of symptoms is really temporally related to when they have their episode. That makes sense in that if you have atrial fibrillation, that you report at least the most severe symptoms right around the time that atrial fibrillation occurred, and as time goes on, that's that your perception of severity of symptoms changes. So if you have a digital therapeutic, you can actually deliver it right on time, or shortly after development of atrial fibrillation, for example. So you could really benefit patients by getting the treatment to them right away, as opposed to waiting 6 months to see their electrophysiologist. Okay, so now how do we put everything together? Which is really a challenge that we've been tackling over the past year. Remember I said that the circle that we kind of discussed in the beginning, where you had to prevent, screen, diagnose, and treat disease. Now we could do that with using our digital technologies in a whole new way, a better way. We can manage symptoms, heart rhythm, using wearable devices, on-demand ECGs, and symptom checkers, like I showed you. We can screen patients using remote patient monitoring, using wearable technologies. We could deliver digital therapeutics remotely, and we can get that information, get it to a clinician to review and generate a report. So we've been doing this in our patients. Our initial cohort has been in patients that have had atrial fibrillation ablation. So what we are doing is, in that population, so once the patient has atrial fibrillation, they get enrolled in our digital health program. As part of the digital health program, they receive a wearable device, and the initial wearable device that we've used is the mobile cardio device that I described to you. We look at their symptoms and heart rhythm transmissions on a daily basis, and a clinician reads those and generates a report, and it becomes part of their medical record. This is what it looks like from when you look at it from end to end. So patient receives the device. That device sends transmissions, which are typically ECGs on a daily basis. Those go to our a platform that we have created at University of Michigan called MyHeart. MyHeart has the unique capability to not only receive and generate a clinical report, but also run a lot of the algorithms that I described to you for LV systolic dysfunction, for QT measurements in the cloud, generate the prediction, and then make it available to clinicians if they need to, and then a report is generated every 30 days. Then that becomes part of the electronic health record. So this is kind of like what it looks like as far from those IT enthusiasts in our crowd. And then there's the billing aspect that we are actively sorting out. We have some answers, but that part is going to be implemented in March. So once that's done, I think we could really start to scale this program across the healthcare system at Michigan Medicine. This is what the dashboard looks like from a clinician perspective. So you see the ECGs that are coming through. They get lined up for us there. You can click on any of those ECGs. The ECG is displayed, and then you can generate your diagnosis if you agree with the one that's generated by the software, or you can make your own diagnosis, and then you can sign it and then move on to the next one. And then the report is generated in the background as well as billing. So that's kind of like trying to bring all of that together. So with that, I try to cover a lot of ground in a very short amount of time. So I wanted to kind of get a sense of like how, there's so many things that have been developed, but many of those things now we can actually put them together, make it available to clinicians, and actually like make informed decisions that can help patients. Thank you so much.
Thank you. It looks like we have a couple of questions from David Olson in the meeting chat. First part of his first question, how many 30-second intervals would be needed to screen for AF with acceptable false positives or false negative characteristics? And then additionally, he asked every 15 minutes for how many times? 200 are similar to your study with vigorous exercise, one day, 1 week, 1 month. And if patients are prescribed a clinical grade smartwatch, how long would they need to wear it to avoid false negatives?
Lots of questions there,
Yeah.
so I'll just go through it. So, it depends on how the 30-second intervals are generated. So if they're generated randomly or as a result of a patient actually feeling the symptoms or some symptoms that may tell you that, or to tell you that the patient has atrial fibrillation. So if you have clinically significant atrial fibrillation, generally you have lots of atrial fibrillation, and generally the episodes aggregate together, and the clinically meaningful episodes are often 1 hour or longer. So if you have symptoms and within at least an hour, you can generate either an ECG or a PVG signal, then you should be okay to catch them. Generally, if you can monitor patients up, the biggest bang for your buck is if you can extend the monitoring period up to 6 months. After that, we see a big drop off. So if you don't catch it within 6 months of prescription of your device, you probably are not going to have atrial fibrillation that you're going to catch. So there's a big drop off after 6 months, and we've seen that with a lot of the loop recorder studies that we have done. The next question was, if patients are prescribed the clinical grades, how long would they need to wear it to avoid false negative? I think that goes to the 6 months question. So 6 months seems to be the right answer for how long they need to wear it as far as the watch is concerned for kind of catching the majority of the clinically significant atrial fibrillation episodes. And yes, the clinical grade watch would need to be reusable. So it would be just like how we are using the 6-lead cardio watches, where patients are prescribed, they're giving to it, and then then they return it to us. Or at least we make a good faith effort to get the device back. We sterilize it and you reuse it. And the same would be true for the watch.
Thank you. Does anyone else have any other questions they'd like to type into the chat, or just shout out over Zoom? Feel free to shoot out a question if you have one.
Oh, this is a Gmo. Can I
Hi,
ask a
Jimo.
question? Hi,
Yeah.
Hamid. Yeah, it was very nice seminar. So And very interesting stuff. So question is, I wasn't very clear when you say 6 month, is it a 6 month, meaning 24 hours per day, continuous for 6 months, or each day you only sample 15 minutes of data?
No, I meant continuously for 6 months. And I'm quoting you the data from our implantable loop recorders, where you for patients that you are suspecting of atrial fibrillation, if you can monitor them for a long period of time, you can catch a lot more atrial fibrillation. But really, a significant number of those patients are detected within the first 6 months.
What is the rate of false positives using the PPG method?
False positive rate, are you talking in general or particularly in the watch that I described?
The watch you talked about, PPG watch, for AFib detection.
I don't remember the precise number, but it's quite high. And generally, the majority of them are because of motion artifacts. So even though not all patients may have this, and what we generated was within 2 weeks. So if you imagine, I don't remember the exact number, but if you imagine the rates being 50% or so, if you wear it long enough, almost every patient will have a false positive PPG signal. Now, that can be alleviated very easily if you have an on-demand ECG on the watch, right? So you have an irregular rhythm notification, you get an on-demand ECG, and then you confirm whether you have atrial fibrillation or not. So that's one way of reducing that. Another way is to kind of getting all that. And then some of those ECGs are also going to be false positive, right? So kind of having the cardiac technician overread is key for all of that.
Yeah. So one more question about the cardiac alive core device. As far as I understood it, they also have lots of false positives and perhaps even false negatives. But anyway, so how do you confirm their detection? Do you also have a technicians to read over it or like retest it with the 12-lead EKG to verify it?
Actually, it's the alive core monitor that we use is a 6-lead device, so the rate of false positives are not that high. In our use, all the 12-lead ECGs are overread by a clinician at University of Michigan. If they feel like that it's inadequate, they can order additional testing.
So we actually in our lab we've been trying to study the false positive rate of the alive core device, but if you buy them from Amazon, so they recommend either you subscribe monthly or annually, and so the signal will be read. You can pay for extra money for signals to be read by experts. So I wasn't sure what the expert is actually by somebody in their alive core company, so they hire as consultant, or is actually by doctors like in the hospital where the patients go to visit. How are they?
My understanding is, and don't quote me on this, my understanding is that they have clinicians who overread, or cardiac technicians who overread them, clinicians. We don't use that here. What we do is we get their ECGs. If they're enrolled in our digital health program, the ECG then gets transmitted to us. There is a AI generated diagnosis that is pretty good. We can either agree or disagree with that. And then if we disagree, we make our own clinical diagnosis and then we finalize that. So we don't use their clinicians.
Oh, so you don't really get the PDF copy of the data, which all the patients get, but you actually get digital data from the 6-lead.
We do. Yeah.
Got it. What's your experience with Apple Watch detection for AFib in terms of false positive rate?
We don't use it clinically yet, so but the false positive rate for that is also quite high for irregular rhythm notification. So So from a PPG, yeah, there's lots of false positives. Are you talking about PPG or the ECG?
I'm talking about ECG, Apple Watch ECG.
Right. So it's a modified lead one.
Yes.
So it's with modified lead one detection of P wave. The P wave amplitude is quite small in a
Yes.
lot of cases, particularly in patients that are obese or you have poor contact or the wrist size is variable. So that you also have a lot of false positives with the PPG, but the ECG signal is quite good. So I often found that you either get poor quality or that you can't determine, or you have good quality ECG, but not a lot of like, oh, I mistakenly thought this was atrial fibrillation. One exception is that if patients have atrial flutter or if they have lots of ectopy like PACs, so that could throw you off sometimes.
Yes. Yes. Okay. All right. Thank you, Hamid.
Yeah.
So just to follow up on that, something like the Apple Watch, is it's limited in its quality. So are you getting a lot of false negatives that patients are coming in saying, hey, my watch told me I have AF? Is that become the new reality? Have we run into that now?
You mean false positive?
Oh, sorry, false positives, yes.
There is a lot of false positives on the PPG signal. There is, however, not a lot of false positive on the ECG signal if a clinician is overreading it. I have to say in my clinical practice, that's not a major problem where a lot of patients have come in with false positive diagnosis of atrial fibrillation from their Apple Watch.
And what about false negatives? So how many patients who think their Apple Watch is helping them, they don't need to see a cardiologist, are getting a false sense of security?
It's hard to know that for sure because you would need like a continuous ECG to compare it to. I can tell you from the studies that we've done, that number is quite low. And the watch doesn't perform well. The PPG signal doesn't perform well in certain settings. And the number one setting that it doesn't perform very well besides activity is very short duration atrial fibrillation. So if it does miss atrial fibrillation, often atrial fibrillation that is 6 minutes or shorter. Now, I would make an argument that that is okay in that those are generally not atrial fibrillation episodes that are clinically significant. But by that, I mean they're not atrial fibrillation episodes that confer a higher risk of having a stroke.
Right. Fascinating.
Mm-hmm.
Oh, so this is Jibo again. So about false negative, I think David brought up a good point. We actually published a study in 2019 in the journal Stroke after conducting Amtrak sponsored study in stroke unit testing, trying to detect atrial fibrillation in stroke patients after their stroke while they're in the hospital and being monitored in telemetry for hours and days, sometimes weeks. So we found of the 260 patients who had a ischemic stroke, 5 patients were falsely detected as AFib patients, meaning false positive, and 5 patients were false negative. So this is comparing what the electrocardiometrics, which is ECM method we invented in our lab, based method, and is further confirmed by a cardiologist versus the detection onset by stroke physicians and nurses at the patient's bedside using the GE's cardiac monitor. So I think false negatives definitely exist. It just hasn't been studied extensively because you really need to have continuous monitoring of the patient's data in order even to find out what was missed by the. It's a far more difficult to deal with compared to false positives.
Yeah, in our study, we didn't have too many false negatives, and the only false negatives we saw were on short duration atrial fibrillation episodes.
It would be interesting to have I don't know whether in your PPG watch study, you had a simultaneous
We did.
wearables using, you had a PPG watch, you also had, let's say, iRhythm Zio patch, simultaneous detection, and you see what was detected on the Zio patch was always detected by a PPG watch. I think that would be, I don't know whether it's done before like that.
That's
feel-
what we did. That
Okay.
was in our study, we had a continuous iRhythm Zio patch.
Oh, so you used the Zio patch. Okay, so the
Mhm.
Zio patch, all of the false negatives were already identified, if there were any that is missed by the Zio patch?
Yeah, so the ones that PPG missed were short duration AF episodes
Hmm,
during vigorous activity.
very vigorous activity, yes. Good to know. Thanks.
There are a couple of other questions in the chat. First, do you anticipate that this device would affect the long-term usage of anticoagulation if no AFib is found in 6 months?
Potentially, I think there's a couple of studies. We don't really know what to do with AFib that's detected on these watches yet. It's conceivable that we need to start anticoagulation in these patients, but we don't have a large clinical trial looking at that. There's a couple of large clinical trials ongoing right now to kind of answer that question. So I think we'll know a little bit more, but I anticipate that there is going to be more healthcare utilization as a result of these. Now it's more ablations, probably more hospital visits, and probably more anticoagulation. And then is there another question? Is there a gold standard wearable for ECG? Gold standard is a wearable patch like an iRhythm or a Preventis patch. So that's what I think we use the iRhythm patch in our hospital.
So, Hamid, I'm sorry, I have one more question. I find that your description of emotional trauma or event actually is more tightly linked to AFib. It's super interesting. Suggest to me it's actually brain problem is the cause of AFib genesis,
Well, I would
or
say
at least has a link.
there's definitely truth to that. I think there's lots of work done there, but what I described was reporting of symptoms, where patients report severity of symptoms and symptoms that we traditionally think of as AFib related, like chest pain, shortness of breath. And they reported more severe symptoms if they had higher negative affect scores. So if they were more depressed, for example, they reported more severe shortness of breath as compared to someone who was not as sick. Does that make sense?
Yeah, is it a more anxiety or stress or some other things, or is it I guess it would be great to actually sort out the link in what kind of emotional states tend to be linked with the sudden precipitation of AFib. Kind of interesting.
Yeah, definitely. I think that would be super interesting.
Yeah. Thanks, Hamid.
Yeah.
I think we are up on our time. Thank you all so much for all of your great questions and the great discussion. And thank you, Dr. Ghanbari, for your wonderful presentation.
Thank you. See you guys soon.
I hope you'll join us for our next webinars. Our next one is on February 7th, and hopefully we'll see you there, and have a good rest of your day.